for Annette. Annette, it's great to hear somebody so involved with the policy end of nursing speaking with so much sense about what needs to happen on the bottom. So well done to you. Thank you. Regarding NCDs, the last time I heard about an epidemic of working people who needed intervention, sorry.
I think about last time I heard about an epidemic of working people who needed intervention in the developing world, it led to the Gates-Clinton antiretroviral intervention, which essentially has now led to our current relative prosperity and that rise in life expectancy, at least in part. Do you ever see a similar intervention politically in terms of drugs access for essential drugs in NCD management? And do you see, have you any suggestions about who might fund initiatives in this area? Because as you pointed out, it's not actually 2%, it's 1.8% of global health funding is spent on NCDs. It's very, very much a poor brother or sister. Thank you.
Great. So take some more questions.
Sorry. Just keeping you on your feet. Anne O'Malley from Concern. I suppose two bits of questions really. One for Dr. Mohammed in terms of the whole growth and development of the health sector in Afghanistan. It is an incredibly difficult country to work in, and congratulations for the advances that have been made already. I suppose one of the things that you didn't talk about at all in your presentation was the whole gender inequality side of things, and it is the most, I suppose, or one of the most difficult places to work in from an equality perspective. And without addressing the root causes, the real progress in health will not be made to any degree. And I suppose the second part of my question for maybe the panel in general, none of you mentioned the role of technology in rolling out a greater global strategy, or the role of technology in improving healthcare. So maybe it would be good to maybe have a word or two on that. Thank you.
And thank you, Anne, for introducing yourself, which I should have said at the beginning. Take another question at the top there on the right. We'll take two questions up there. You won't have to run as far this time. We're concentrating the questioners.
Good afternoon. My name is Cleona O'Sullivan from East. My question is for Sherly, and thank you all to the whole panel for really, really interesting presentations. And Sherly, it's just in relation to the youth network for the global health workforce. And my question is about your work, or your plans for work around increasing the access and availability of education and training for health workers in those middle-income countries. And is there kind of strategies and activities in that area?
My question to Annette is that the United Nations political declaration on NCDs acts on three levels: national, regional and global. And I'm wondering, have you been able to do anything to develop an interest in our global responsibility as a nation in this regard?
Now we take one more, Dermot.
Could I just ask if Dr. Haqmal could tell us just a little bit more about the $1 project?
Okay, we have a series of questions. Maybe we just take these questions, or else our speakers will have difficulty keeping them all in their heads. So one on drugs and access, who will fund that, on gender equality in Afghanistan, and on the role of technology, education and training in youth. Michael, you might need to just reframe yours, I didn't catch it. And one on the $1 initiative.
Okay, for
Annette.
This works?
Yes.
Yes is the answer to your question about funding. The report from the NCD Commission is looking at public-private funding, and it is a huge issue because it was one of the three major areas that was looked at. So yes, the answer to your question is I think the global agencies recognise that this has surpassed all infectious disease epidemics. and it's going to get worse. It's taking up all the funding from everywhere else, and if we don't get in there in a whole lot of different areas, they're looking at, yes, as you rightly say, drugs for hypertension, drugs for cardiovascular, like statins and all of that. So all of those areas are being looked at. I think, to be fair, the agencies and governments have to recognise that NCDs is the biggest problem down the tracks. In Osaka, in Japan, the G20 were talking about investing actually in health systems and investing in the health workforce, because there is no investment in health systems in many countries, particularly the ones that need it, the lower and middle income countries. But that isn't to say that NCD isn't affecting the whole world. So we have to call those agencies to account.
Yes. Question maybe, yes, from Anne on gender inequality and on technology.
Yes, I think it's a very important question, question regarding the inequality and also gender. The good things that sometimes we are complaining from the donors, but there is also good things among the donor policy as well. All the time when we are meeting them, we are asking us about the gender inequality achievement. So in Afghanistan, the number of female ministers in the current cabinet, it is 35%. In developing countries, unbelievable. The number of MP in the government is also almost 40%. Health facility, we do have problems, especially in insecure area. I think I mentioned at least in 80% of the health facility, we have at least one female health worker. That means they are also receiving training regarding the genders. So we have strong support from the United Nations, from the WHO side as well. So in genders, we have been trying. Still there is a long way to go, but we have something, like at least we are convinced so far for the achievement of the last 5 years. Coming back to the question of the IT technology, we have started something since 1 year, and it's a very interesting project. In Afghanistan, we had a problem with mortalities, and I will link that technology, which kind of technology we are now using, in health service provision. In 3 provinces with the highest maternal mortality, we distributed simple mobile to community health workers. So this mobile is connected with the database in computer in the provincial level and also national level, even in the presidential level. At least our first lady know at the end of each week how many women died in those 3 provinces. And then we have response and investigation team as well in that area. When we get the report from that particular villages and also provinces, pilot project, we share, we send back. There is also already team in the district level, district health officer and also his or her team. So they are doing the investigations to verify the data. Then there is the response team working together with the implementer partners to make sure that whatever problem is there, it should not be there, and also to tackle, the challenges. And the other question was, I think, about, let me see the question. $1 project. Wow, very interesting. I think now I'm happy, at least I have flexible time, to talk about it. So I don't see any hands now. So the provinces that I discussed with this 6,500, mortality, it is somehow isolated. It's not well connected with the provinces. So many people are not going there and they are not coming to us. It is a kind of psychological barrier between us and also others. I spent 2 years here in that province. When I went there, I was rejected. I was not able to go and work with them because my clothes was different, my style was different. Then I came back and I spent 1 month at home to make myself similar to them. And then next time when I went to them and I spent a long time with them, 2 years. Within this 2 years, what happened? When I returned back, many people thought, well, I'm not alive and I'm dead because for 2 years disconnected with all the services that you are thinking. So these people in those areas, they are still changing things. They are not used to have cash, no money. This is the old classical method to have business they are dealing. So when I went, I discussed with them, about some of the reasons, So when I found out that at least there was 150 reasons why they were not using the services, even some of the health facility was in their area. When I discussed with the health facility staff, they also they come up with a kind of solution. They was complaining about the low awareness of the community. I told them, well, there is low awareness, but as a government, this is our responsibility to increase their awareness. We should not blame them that they don't know anything, they don't know about those things. So then, for $1 project, we found some reason. For example, private sector was playing a negative role in the health services here. So they were selling some medicine in those regular shop. So in regular shop, when you go, you can also buy, other stuff along with the medicine. So there was some tablets with red colors. I forgot that tablets, but it was antibiotics. 20 years back, this used to be with the same color painkiller, paracetamol, and others. And now it was antibiotic contraindicated for most of during the pregnancy. So people were buying antibiotic instead of painkiller for their treatment, and they were giving to the pregnant women. So that's why antibiotic was one of the high reasons, for the mortality there. And then there was a religious treatment. So many people were going to the religious treatment, and they were advised to not eat anything except drink water for 50 days, 50, or 40 days. So then imagine if a pregnant woman is not eat anything, then what would happen? Then the last thing, it was traditional bed attendance. It's very nice words in WHO, but this is not traditional bed attendance of the WHO. It was traditional bed attendance of my village, where I was born. So many people were like born, helped during deliveries by those traditional bed attendants, and they were, the delivery was happening in those very dirty rooms without any hygiene. So then imagine if there is no infection prevention thing during that time, what will be the result of those postnatal care and also this complication. And then other things was nutrition. Many people, because of the low awareness, they were selling their fruit and vegetable, buying something which is unnecessary for them, sweets and also some cookies, those things. So then we link most of those things in order to increase, the demand and also demand for the health services, and refer most of those cases to the health facility. We give them a kind of incentive of $1. For example, traditional bed attendants from that area, we were paying $1 because she was receiving $1 from, from the family to help, during the delivery. We were telling them, well, get $1 from the family, we will also pay you $1. At least try to help to bring, this pregnant women to the health facility. So inside the health facility, the delivery will happen under your observation. And so the doctor will also listen to you, whatever you are saying, at least to convince them to refer that cases to the health facility. Second thing, private sector, we told them, well, you are also receiving some benefit of $1. We will also pay $1 whenever you have any kind of pregnant-related cases or children under 1 or children under 5. Refer those cases also to the health facility. The other things, local terminology was one of the biggest challenges. I think it is in many countries, in many developing countries like India. So they are using the local terminology of the ground, but unfortunately we as a healthcare provider, we are imposing our medical terminology on them. So when I asked, for example, several things for abdominal pain, for headache, they were using their own words. But our doctors from the capital of the country or capital of the provinces were taking a distance because they could not understand each other. And then we found 150 terminology words. We trained the health facility staff on local terminology. So in fact, $1 was linked with somehow those barriers, to remove the barriers and to make sure that these people are coming, to the health facility to receive the services. So there might be one another questions behind that one. It was sustainable because, for example, many people are going to the traditional, for the religious scholars, and then the religious scholars were referring those cases to the health facility and receiving $1. For the future, people will not go to the religious scholars to come through the religious scholar to the health facility. They will come directly. It's the same also for the traditional bed attendants. It is the same also. And we also started community outreach and community ambulance services. I think later I can discuss in detail with people.
I think that's the best value we've ever had for $1. Shirley, health education and training initiatives for youth.
Okay, that's a very interesting and important question. Thank you very much for the question. I hope that I can answer it actually. So actually, yeah, investing in the youth, especially education and training, is very important. But for Youth Hub now, we basically how we can improve the education and training. We have like confidence space, the one that I mentioned before. So it's basically we aim to ask youth to share their voice. They will build a team and they can brainstorm about the problem, the challenges that they face, and then they can provide innovative solutions related to education and training. So, but actually for this year, we more focused on decent work, so we are not really focused in education and training. But I think it can be a very good idea. Maybe next year and next 2 years we will invest, because education and training is also important. And I can speak on behalf of my experience, because my current research is basically to provide education and training for young pharmacists in Indonesia. So we are planning to build a foundation training, because what happened in Indonesia, as a pharmacist, whether you just graduated or whether you have like 30 years experience, you still have the same you don't have improved competency. So basically that's what I'm building now in Indonesia. So I'm building a tool which can help pharmacy to improve their competency, so they can advance in their careers in terms of providing services to patients.
Great, thank you.
Thank you very much.
Michael, can you very briefly say what your question was? I'll take one here from Dick, and then I think, to be fair to the parallel sessions, we'll need to move on. Just very briefly, what was the question?
Basically, that the United Nations political declaration on non-communicable diseases, which Ireland has signed, covered both national programs, regional programs, in our case EU, and global programs. And in particular, that would be our sub-Saharan African countries. And I'm wondering, have you been able to do anything to create interest in this aspect of the NCD program?
Not enough, probably, but yes, I am trying, that's for sure. They are doing some things which you probably don't notice so much in relation to health literacy. And that's a huge area that the NCD Commission are, I suppose, promoting. So yes is the answer, but no, I would like to do a hell of a lot more, but then I would like to do a lot more in relation to a lot of things, because I think that, you know, it's extraordinary. Just one quick story, and I was talking to some of my colleagues across the world. In the 1970s, I hate to say my age, but anyway, in the 1970s I went to the United States. And I hadn't seen a fat person at that time. I'd never seen a pizza. I had never seen eat as much as you want and all of that kind of thing. And now it's hard for us to see somebody thin in Ireland. So, I mean, we have changed dramatically in a short time. So, and that's happening right across the world, which is a terrible indictment, and particularly in Asian countries. And just get back to a question which I didn't answer, and that was in relation to technology. You are absolutely right, but it's hard to cover everything in a couple of minutes. I have been more impressed by what's happening in the Asian countries in relation to technology than anywhere else in the world. And in fact, I think they're models of healthcare, and they're models of, not particularly in relation to primary care, because that's not so great, but in relation to how efficient they are in delivering healthcare in hospitals and those areas. I think we could learn a lot more from those countries than taking them from the countries that we currently replicate bad practice.